Toby Clark, and pulse ox.
Thank you, Tom. Thank you, IFMBE and WHO. Pulse oximetry, we had a town hall on May 15th, and it was well attended. I want to thank Kito Fukuta from Japan, who was the co-chair of that session, all the panelists. In terms of the speakers, we were fortunate to have Adriana Velasquez lead off that particular town hall. And important statement, pulse oximetry being an indispensable medical device essential for patients receiving oxygen. And it's something that's needed through all stages of healthcare, from primary level to the tertiary intensive care. I think a good comment that came out of that was it's the fifth vital sign, as Yadin David made that statement. Adriana went through the WHO resources on priority medical devices. They're robust, they're high quality, they're freely available. I won't spend too much time discussing those in the interest of time, but certainly a super resource for everyone to utilize. Answered a lot of the questions that came up in the chat on the Q&A. So we had a great speaker, Pauline Baguti from Rwanda, that talked about the clinical side of pulse oximetry use and the importance in the use of it in triage and screening. It's a key area as an early warning device for patients who have experienced coughing for, say, a week, recently traveled, been exposed to COVID-19 positive individuals. So this, he discussed the use of it, emergency department, primary care, home, etc. And this was an important learning experience. In the hospital setting, such as an ICU, he also discussed the essential application of pulse oximeters for applying the Kigali modification to the Berlin Protocol, which is very important in low and middle income countries who don't have lab-based blood analysis of oxygenation levels. So by using the SpO2 and the FiO2 and some measurements, the oxygenation threshold for diagnosing respiratory distress syndrome is utilized, and that's very effective. So thank you, Dr. Bengati. In terms of clinical engineering, we had Sharifu and Ali and Dan Schuster comment on the use in Tanzania for clinical engineering, doing an analysis of fingertip pulse oximeters, determining that in many cases they are less accurate, particularly in the hypoxic ranges, below 85 or 90%. However, they're still valuable for screening because they show trends towards hypoxemia, and they're also useful in absolute readings in that range of 85 to 90. Clinical engineering testing using simulators is typically better than self-tests, as it allows for 2-point calibrations, and that's an important check of accuracy. However, they did discuss some of the problems that occurred related to temperature effects. We were also had Yadin David and Elliot Sloan talk about the global approval bodies for medical devices, CE Mark and FDA. There are other bodies throughout the world that basically provide approval. In the case of the FDA, it really only provides clearance for devices. The FDA, they do not evaluate or test the accuracy, safety, or other performance. They refer to standards, and those standards are submitted, the compliance with those standards are submitted by the manufacturers. So they're not really evaluating devices. This led on to a discussion with Adriana and others on the panel regarding devices having approval, and this goes throughout the whole priority medical device field, medical grade versus non-medical grade devices. In the US, we would call those consumer devices, the non-medical grade. So an example in terms of pulse oximetry, wellness or sport classified pulse oximeters. So the panelists were Kostika Twanza, Dan Schuster, Tom Judd, Elliot Sloan, Yadin David. It was a very active session. We had over 30 questions and answers that came out, and those are mostly answered by our panelists and experts, and we will get those out to everyone. So there's still a lot of work to do. We can only achieve this by sharing, questioning, and working together. Thank you.
Thank you, Toby. Are we, all right, so I'm sharing the poll results. Are there any questions in pulse oximetry area that the panel wants to answer or sees? Seeing a lot about the biggest challenge for pulse oximetry is specifications.
Well, this is Elliot. I'll point out that one of the challenges we have with the enormous demand for fingertip pulse oximeters is that at this point, there are very few vendors who have devices that have traceability back to CE or FDA submissions. So I would encourage everyone to include that in their requirements and try to obtain devices with that documentation if at all possible. It is really a struggle because the global supply is depleted, and even in the US, most devices are being drop shipped directly from China. And we're having difficulty sourcing documented devices.
Thanks, Elliot. Other responses?
Well, pulse oximetry is basically a lot of the original results, and pulse oximetry is based on empirical studies. There certainly is science behind it. It's kind of like non-invasive blood pressure, where each individual manufacturer has a algorithm for determining diastolic value. In pulse oximetry, when we get down to the hypoxic range, that's when problems occur. So looking at specifications for that range is most important.
And I'd also like to point out that in the supplement that we have posted at the webinar page, there is substantial research that has been done to document inaccuracies with persons with dark skin pigmentation and also sickle cell anemia. And those are both common conditions that have to be aware of. And apparently the inaccuracies read falsely high O2 levels in persons with those skin or sickle cell types. So one has to be very cautious in using, for example, an 80% threshold if the device is, by its limitations, inaccurate.
Thank you, Elliot. We're going to move on now to